A very good afternoon, everybody. I welcome you all on this Saturday afternoon for the MOGS Mumbai Obstetrics and Gynecological Society webinar on fever in pregnancy, a power-packed panel discussion, which is brought to you by TOG and Science Integra with our sponsor Sun Pharma. Fever in pregnancy is the most commonest complaint which we see. And nowadays, with this COVID pandemic everywhere, other cases of fever in pregnancy are also masked. So let us revisit and spend our afternoon time revising, recollecting, and discussing the common causes of fever in pregnancy, the differential diagnosis, and utilize our time well for academics. So, to begin with this, I call upon the moderator for today, Dr. Niranjan Chavan. Dr. Niranjan Chavan is a professor and a unit chief at LTMGH Sion Hospital, and he is also the secretary of Mumbai Obstetrics and Gynec Society and Secretary General of Maharashtra chapter of IAG. He is a professor at the busiest medical college in the city of Mumbai, Sion Hospital, and having more than 30 years of teaching experience. Before we begin the panel discussion and everything, uh, I would like to welcome all the panelists and so that we have a very good discussion and we can give apt take home messages. And at the outset, I would like to thank our President MOGS, Dr. Jaideep Tank, who has willingly given us the permission to conduct this academic feast for all benefit of all our MOGS members. Thank you very much, sir. And hand over to you, Dr. Niranjan Chavan.
Thank you, Dr. Komal Chavan. Being the secretary of the largest organization of our FOXY, Mumbai Obstetric Gynec Society, is a very big task. So obviously, I just talked to Dr. Jaideep. Jaideep, we are in lockdown right now, and I think should we have some CMEs, webinars? So he said, yes, Niranjan, we should have for the benefit of our members and also for the FOXY. So I welcome you all. And today the discussion topic will be fever in pregnancy. And we have esteemed panelists. And I call upon our first panelist, Dr. Vanita Raut Madam. Vanita Raut Madam was the professor in St. GS Medical College for more than 20 years. And then she went and became the unit head at Dr. L.H. Hiranandani Hospital, Powai. Also the past president of MOGS and has numerous clinical trials and publication. Madam will be joining us very soon. She has a emergency case, and we will get back to her very soon. Next, we have the eminent professor from Rajasthan, Jaipur, none other than our FOXY Vice President, Dr. Leela Vyas. She was in 2018 the Vice President and also the Professor X in the SMS Medical College. Presently, she has her own hospital and her clinic, and she is consulting in Cocoon Hospital and Vyas Clinic. Welcome, Madam.
Thank you.
Next, please. I call upon our own MOGS member and the joint treasurer of FOXY, Dr. Parikshit Tang. He is the consultant at Ashwini Maternity and Surgical Hospital at Ghatkopar and also visits the Jupiter Hospital in Thane. And he was also the chairperson of the Safe Motherhood Committee, FOXY 2014-17, and has got numerous awards and medals to his credit. He has more than 100 peer-reviewed publications and has also co-authored textbooks and books. Welcome, Dr. Parikshit Tang. Dr. Murlidhar Pai. He is an eminent professor in the Manipal Medical College. He has been also a teacher for more than 35 years. And we welcome Dr. Murlidhar Pai. He has got 164 publications, 385 presentations as guest lecturer. Has also been is rather the author of Holland and Views Manual of Obstetrics 4th edition. He has 33 years of teaching experience, and I welcome Dr. Murlidhar Pai. Please come, sir.
Thank you.
Dr. Vanita Raut has also joined us. Welcome, madam. Can you hear us? Dr. Vanita Raut, please unmute your mic. Thank you so much to join us. Now we also call our next eminent panelist, Dr. Parag Binniwale. Presently, he is the secretary of ICOG. He has his own consultancy, a unit at and PG teacher at Kamla Nehru Hospital, president of the Menopause Society Pune, and he was also the national joint secretary of IMS. He has also got many publications to his credit and has given more than 120 guest lectures and oration in Foxy societies. Welcome, Dr. Parag Binniwale.
Thank you very much.
I request all of you to unmute your mics and you can see clearly that we will be presenting today and the topic is fever in pregnancy. So Dr. Vanita Raut, can you hear me? Madam, there is some issue about the audio. You have to adjust your audio. I request you to please unmute your mic and see that your earphone is connected to the laptop. Thank you so much. Now we start with our question answer sessions and we have wonderful cases lined up for you. Dr. Vanita Raut, can you hear me? I think there is some audio issue. There is some audio issue with Dr. Vanita Raut. No, madam, we can't hear you. We will get. Yes, can we hear loudly? Thank you, madam. Dr. Vanita Raut, can you hear me? Yeah, but I think there is some audio issue. Okay, we will go with the question now. First question. The first question is, the first case we would like to go ahead. She is a 30-year-old, third gravida, para 1 with 1 abortion, presently with 2 months amenorrhea, with fever, and she has some chills on and off, and she has come to our OPD for MTP. So how would you treat her? Madam Vanita. I think what Vanita madam is to check her headphone. We will pass this question to Dr. Leela Vyas. Dr. Leela Vyas, please go ahead.
Yes. Good afternoon, everyone. And this is the one of the common problem which we are facing. 2 months amenorrhea with fever and coming for the MTP. So first thing is that if she is coming for MTP and with fever, definitely we have to defer this procedure of MTP until unless we diagnose that what is the cause for this fever. So by history, as she is having only complaint of chills and rigor, it is off and on. So other conditions, other problems are not associated. Detailed history we have to take. Any GI problem or any respiratory problem is there, but the single 2 points are there. So if this chills and rigors, definitely the most common cause which we see that it may be because of only UTI or maybe because of the malaria, because malaria in India, the common malarial conditions are there. Malaria is prevalent in some areas, much of that. Then other conditions with the fever, definitely we all are having this all infections like dengue. So we have to take that how long history is there for the fever. And I think fever, if it is a short history, definitely the basic investigations we have to see, and the temperature control is required in pregnancy. Because this time we are deferring this procedure of MTP. I think that sometimes the patient may change their mind that they are not going for the this MTP procedure. They want to continue it if everything is going well. So this first thing is that to control the temperature and then accordingly to investigate for the different causes like UTI and for this malaria. These are the 2 common things. If suspecting other causes like the high grade fever, any rashes and the other things are appearing, then rashes and all, definitely the dengue is, which is a very common, and now the season it's definitely it has slightly passed, but the cause is there. Then
she's talking, so I won't be able to speak in between. Can you hear me?
Yes, yes.
Dr.
Yes,
Rao,
Yeah,
yes,
you can
hello.
continue.
Raut, madam.
Ma'am, you can
Welcome,
continue
madam.
with this question. For the
Fine. No, I suppose you should take this because I was not able to hear what you had already said. So I think
Okay.
you should finish it. I can go take the next question.
Okay, okay. So, in this case, means for UTI, urine complete uncultured, CBC, blood film for
Yes,
malaria,
madam.
this we have seen. And then if suspecting dengue, definitely NS1 antigen, which we have to see, which comes the first, it is, and then if fever persists long, then definitely IgG, IgM, PCR, that we have to confirm these. Because these are the common things. Then we see that the procedure further in symptomatic treatment we have to give for that, and suspecting any bacterial infection like UTI, then this treatment madam will take. But these basic investigations to be done, and then we see the progress of fever, how it is progressing, and then further decide for her continuation or termination of the pregnancy.
Madam, so I may ask you, Dr. Vanita Raut, madam, that we have this patient who has come for MTP. She is 2 months amenorrhea and she is 30-year-old, already having one child and one abortion, but she wants to have this abortion and do a tubal ligation. We will come to that. So what do we do? Should we treat her first with fever and chills, or should we admit her, or should we send her home, or means what? How would you
See,
go about?
it depends upon how many days is the fever. It will all only depend upon how many days is the fever, how high is the fever, is she looking toxic, what are her serology or what is the microbiology, means what is the cause of the fever. I don't think we should go ahead with the MTP immediately unless and until we have diagnosed why the fever is there, and depending upon that.
Absolutely.
So it will all depend upon what the diagnosis is, and then only once we diagnose, we treat it, and then only if she wishes to do the MTP only for a social reason, then she can go ahead, because otherwise just the fever, even if it is dengue, it's not supposed to affect the fetus. But having said that, even if there is any high fever because of any cause, that sometimes itself can cause a early abortion. Even if it doesn't have a teratogenic effect, just because of the high fever, the febrile illness can lead to an abortion.
Okay. Thank you, Dr. Vanita. We go to Dr. Leela. We have admitted this case, as you have already said and sent all the investigations, madam. I would like to know from you, what treatment would you like to go ahead and give her? Dr. Leela.
Definitely, once we have investigated, definitely if it is simply because of the UTI, then the antibiotic is choice as per the culture and sensitivity. We'll go with that. Then we were suspecting, because the most common thing is the malaria is there. Then definitely the malaria, if comes positive with the malaria and it is simply of a Vivex type, then the
Yes.
drug of choice is even the chloroquine. We can prescribe for the chloroquine. During pregnancy, the quinine is also quinine plus the combination of clindamycin. Again, it all depends on the severity of the disease. Then again, we can go with the, as per WHO, they have given a guideline that artesunate can be given in combination with or a single drug. These drugs can be given for the malaria. If it is suspecting in fever, the high grade fever is there, means the common cause we are not able to diagnose, and suspecting the dengue fever, definitely in dengue, the symptomatic treatment is more important. In symptomatic, we have to take care of fever, temperature, we have to take care of that. Temperature should be come down. The hydration part we have to see. And then further the investigation. The investigations like that CBC, which is very important. And to see the clinically also the any presence of rashes or other things are appearing with that. So the control of temperature, that is with the paracetamol, that definitely it is a very safe drug. Even in the pregnancy and especially in the dengue also, only the paracetamol, whether the lady is not even pregnant, we prefer that paracetamol, and CBC monitoring is required to see the hematocrit and to see the platelet counts, and leukopenia, as we know that the counts decreases in that. So according to that, we have to manage the patient. Same way, if severity with the malaria, the oral to shift to the injectable treatments. So this we can give, and same with the UTI. We all know that if UTI is severe, then again the injectable antibiotics as per the culture and sensitivity. And this is there. Other symptoms if arises with the respiratory and all, then we will think for the further investigation.
Madam, we will come to that. Thank you, madam.
Yes.
You have given a wonderful explanation following admission of the patient and investigating her, having in the back of the mind a lot of other things. But I would like to ask Dr. Parikshit Tank. We have got certain things and lot of things going in our back of our mind when we have a case coming with fever, with chills, without chills, or rigors, whether it could be this or whether it could be that. MTP is obviously, Dr. Vanita madam has told that we are not going to be taking it primarily important, and obviously we are going to treat the disease. So Dr. Tank, how would you now go ahead and try to tell us what DDs could be there, and then further to go ahead with this?
Unmute yourself.
Please unmute, sir.
Yeah, here you go.
Dr. Parikshit.
Right. So as far as this situation is concerned, I think being obstetricians, let's accept that we need a hand here. We need to involve a physician at this point, especially if the woman is sick enough to get admitted. So in that situation, I would really request for help, take a referral from a good general medicine physician, and then proceed. What are we thinking of over here? I mean, essentially, the important aspect in the differential diagnosis is looking for localizing symptoms. So if you have the typical fever with chills living in a tropical country like ours, and especially in endemic areas like Mumbai, then the almost automatic response is that this must be malaria. If you're practicing from 2005 onwards, then you will say it's dengue. So these are the very broad kind of differential.
And now in lockdown and in lockdowns.
So the malaria, I mean the mosquitoes are not locked down; they are freely roaming around. So these are the two important things as far as fever with chills go. Then of course, fever with chills could also indicate any septicemia or bacteremia. So any severe systemic infection can also cause this kind of a fever with chills kind of picture. So what's likely? Let's look at it that way. I would say what's likely is a urinary tract infection. Once in a while, maybe a respiratory tract infection might present like this. So these are the broad aspects of the differential diagnosis that we need to keep in mind.
Okay. I think we have to see all these things in mind. And Dr. Parikshit, you have given elaborate DDs, but still there are certain diseases which are seasonal, and obviously now in summer season there might be not seen these diseases, but we will have to investigate, as Dr. Leela has said, and also further things have to be kept in the mind. Blood smear is very important, and you know what, in spite of a patient having fever with chills, and we do a blood smear, or we do, the parasites are not seen. But when we start chloroquine and the treatment for malaria, the fever responds and it goes. So it is not always that the parasites have to be seen in the blood smear and we have to diagnose it. So excellent, absolutely fine. And we are more worried that this fever doesn't go up and she has some cerebral malaria, or she goes in hemorrhage or DIC and then secondary causing thrombocytopenia. So obviously, Dr. Leela Vyas has already told, and I would like to reiterate here, that we require to do a RFT, LFT, and find out the platelet count, etc., and see in this case. Now I come to Dr. Murlidhar Pai. Sir, would you like to add some more DDs in this case?
Yeah, thank you, Niranjan, and good afternoon, everyone. I think they have covered most of the infections that can occur. But in Manipal, we are seeing lots of cases, especially from North Karnataka region, other districts, neighboring districts, coming here with leptospirosis. It's very
Yes, sir.
yeah. Leptospirosis is also one of the important differential diagnoses that we have to keep in mind. Usually the patients have fever, not so much of chills, but there will be a lot of myalgia, especially the calf muscle tenderness. They will also have redness in the headache, and they will have sometimes even the diarrhea, vomiting, nausea, all these things. And they will go into hypotension to complicate and color the picture in a different way. So we have to, whenever we give consultation to physician, the first thing on their mind is leptospirosis actually, because that's what the cases they see a lot, especially seasonal variations will be there. So for that, usually if it is in the initial part, first 4 to 5 days, it's only the blood they will send. And there are 4 different ways of isolating them. One is by microscopic examination, which you require an immunofluorescent technique, or you may require a silver impregnation technique or a dark field technique. But then culture isolation is also possible, but mostly they will go for immunological tests, anyway, microscopic agglutination test, or they can also go for a latex agglutination test. It can also be isolated with the molecular level with the PCR test. So whatever it is, this differential diagnosis has to be kept in mind, because most of the mild cases can be treated with a simple doxycycline, 1 BD, 100 milligrams, 1 BD for 1 week to 10 days. And this is not at all contraindicated in pregnancy, including first trimester, because unlike other tetracyclines, doxycycline will not cause any of the teratogenicities or even the discoloration of the teeth and things like that. If somebody is worried about giving doxycycline, somebody cannot tolerate doxycycline, then you can go to usual amoxicillin, 500 milligrams 4 times a day. Whereas if it is severe cases, you may require parenteral therapy, which will be either penicillin, or you can also give ceftriaxone. All these kind of drugs can be given. So I feel this differential diagnosis also should be kept in mind, though may not be common everywhere. But wherever you have the experience of this, you have ruled out malaria, ruled out dengue, you have ruled out urinary tract infection, you have ruled out all sorts of infections, then it is worthwhile considering leptospirosis. And we have certain fatalities also in non-pregnant ladies and in other cases. So this has to be kept in mind.
Thank you, sir. Wonderful whole description which you have given about leptospirosis. We usually see in Mumbai at the time of just beginning of the rainy seasons.
Yes.
Dr. Vanita Raut, you would agree with me?
Yes, definitely. We do see, and especially whenever there's a flood, we used to see lots of cases in KEM. Of course, over here in private, we don't see so many cases of leptospirosis, but come one flood and the wards will be flooded with leptospirosis.
Yes. Madam, what about dengue? Can you elaborate something on dengue, about IgG, IgM, and then further treatment of dengue, if that is also kept in the back of our mind?
Right. Dengue will, first of all, the NS1 can come positive by about, say, 3rd day. But to start to take care of the patient, one doesn't really have to wait for the NS1 or something. Only the clinical picture, the first leukopenia or decrease in the WBC count, and one can start. Dengue comes in a 3 phases. The first phase is a febrile phase, the second is a critical phase, and third is a recovery phase. In the febrile phase, there is a very high fever, and one has to just take a care by oral hydration if patient is able to take. Along with that, if there is a lot of nausea, vomiting, one may have to give a IV fluids, but see that she remains hydrated. It's mainly the symptomatic treatment. Typically in a dengue, once the fever starts subsiding, this is the time now the platelet count will start dropping and the hematocrit will start increasing. Now this is a time patient may go in a critical stage. There can be a capillary leak and there may be an extravasation in the extravascular compartment and patient may become bad. This stage can affect even a multi-organ like a ARDS, renal and hepatic failure. So this is the most important, very critical stage where the hydration has to be maintained properly. And usually in a critical stage, one has to give it by intravenous fluids, earlier a very high flow, and then later on you can decrease the rate of the flow. What is important to notice over here, you have to give an isotonic solution and not a hypotonic solution. The best solution is a point normal saline. If not, lactated ringer can be given, but should not be given only the dextrose. With good care, with a symptomatic treatment, patient will start improving. And then the recovery stage starts. Now the capillary leak starts getting sealed, and that's why the fluid starts coming in the intravascular compartment, and this will be seen by three things. One, the WBC count will start increasing. Second, the hematocrit will start dropping. Now, not only dropping, because there is a dilution because of the absorption of the extracellular fluid, hematocrit may be even go a little below the baseline and the platelet count will start increasing. Only one word of caution over here, that now we don't have to give lots of fluid because there is a fluid which is coming into the intravascular compartment, and if we overload the patient may go in a pulmonary edema. Once the WBC count and the platelet count starts rising and there is a rising trend, and if patient is stable, we can even discharge the patient. I think that should capture the whole thing.
Excellent, madam. I am thinking today I am sitting in an undergraduate class. The way you have explained to us.
You are looking like one.
Madam, the way you have explained, I am going back in 1985 when I was a student and you were our teacher.
So
and
good,
the
that
same
makes
feeling
me.
I am getting here. Yes.
Yeah, so
Yes,
that makes
madam,
me also younger. I also go to 85. Okay.
Madam, and I would like to add here to everyone, we have got more than 300 students, postgraduate students. Unfortunately, their exams have got postponed, and we have come to know that many students from all over India and across abroad also have joined to hear our clinic on fever with pregnancy live webinar. Excellent, madam. Thank you so much.
Thank you, Niranjan.
And we have covered this aspects of fever in pregnancy. And I think let's now do her MTP after she has undergone the fever subsided. Later on, we can go ahead and do. Is that right?
Yes.
Yes.
Yeah, I think we should wait for at least 3 or 4 days that she's afebrile, she's clinically stable, systemic changes have reversed, and then we can go ahead with the procedure.
Okay. Thank you. I think that is the right decision. Now we go to Dr. Parag. Dr. Parag Binniwale, this is a very interesting case. Please unmute your mic. She's 24 years old, young lady, primigravida with 36 weeks amenorrhea, and she has got blood pressure of 160 by 100 millimeters of mercury. She has also come with the burning micturition and fever with chills. So we would like to hear from you. How would you manage this case now, who has come to your OPD clinic?
Okay, just couple of questions before I answer. Is she a known hypertensive, or is this the first time her blood pressure was detected to be 160/100?
She had 1 or 2 readings also. Before, one reading was also 140 by 100. Now
Okay.
she has got the second, which is there.
Right. So we have multiple problems here to tackle with. So this patient definitely needs admission, and a good history taking is extremely important. First of all, history, one part has to be related to the fever, whether she has come in contact with any of her acquaintances or relatives who has traveled abroad, with especially with these days of COVID, because that is something which we ask each and every patient nowadays. Right now, since she's 36 weeks today, it is important for us to find out from her regarding this. That is number one. Secondly, we also have to look at the symptoms, whether she has any premonitory symptoms because of the high blood pressure. So these are the two things which have to be asked in detail and monitor. Of course, we would like to investigate her firstly for the fever, which was elaborately discussed in the first case. And of course, we would also like to involve an intensivist at this point of time itself, because she's a patient who has to be admitted to a tertiary care center and has to be under joint care of obstetrician as well as intensivist, because we don't know what is going to happen in next couple of days, because she can land up in problems because of high blood pressure, and as well as we have to counsel her and diagnose the reason why, why she's getting fever. So here, with the consultation of intensivist, we would take a step further. Of course, she needs uh, fetal monitoring as well, and we need to start antihypertensives for her also.
Dr. Parikshit, would you like to add here something?
Yeah, I think what clinicians are worried about with this kind of presentation is the intersection of preeclampsia and urinary tract problem. So where do these two issues intersect? Right from assessment. So, for example, with a urinary tract infection, you're going to have proteinuria, and that proteinuria cannot be distinguished whether it's from the preeclampsia or from the urinary tract infection. Secondly, you're going to have a situation where, in case this urinary tract infection has ascended and gone into a pyelonephritis kind of picture, you're going to have abnormal renal function. So again, this is a common feature which could be there with preeclampsia leading to a renal problems, as well as a urinary tract infection which is flared up. So these are the situations which call for a really astute clinical evaluation of the woman, and always think about the more serious problem first. Here, obviously, the more serious problem is the severe preeclampsia, and therefore I would prioritize that. I would say all the abnormalities are because of the severe preeclampsia. I wouldn't attribute anything to the urinary tract infection, and I would make my decisions accordingly. See, this woman is already 36 weeks, so sooner or later we are looking at delivering her. In short, I mean, if we are to just sum up the matter.
Okay. Now, in case of burning micturition, Dr. Poi, how will you manage this case? Now, she is urinary tract infection with PIH, query, renal disorder, fever with chills.
I agree with
Dr.
Dr. Parag as well as Dr. Parikshit. Before I elaborate on the management, first we have to broadly understand what is the problem with fever in pregnancy. As has been told by other speakers in the beginning, in the first early part of pregnancy, we are mostly worried about the spontaneous abortion that can occur, or in a very high degree fever, there can be sometimes congenital anomalies depending upon the type of infection. Later in the second half of pregnancy, first part of the second trimester, there can be again abortions. Whereas in the third trimester, we are more worried about the preterm labor, pre-labor rupture of membranes and all that. Towards the end, we are more worried about the sudden IUDs that can occur with high fever due to any reason. And in labor also, even 1 degree rise of temperature in the mother will increase 2 degree temperature inside the uterus, and that can give rise to asphyxia and fetal distress. So in this backdrop, if we look, the fever has to be aggressively treated, and in this case, the question is urinary tract infection. Culture sensitivity has to be sensed right away. Without waiting for that, we should start parenteral broad spectrum antibiotics, and we should have already contemplating the delivery. So aggressive fetal monitoring has to go on. If there is any sign of fetal compromise, also with the mother having preeclampsia, in this particular case compounding, we have to consider delivering her as soon as there are any indicators to deliver the baby. And also, of course, mother's condition deteriorating. So, in other words, we have to have a close monitoring of the mother in terms of preeclampsia, fever, and urinary tract infection, which may be going into pyelonephritis, as well as the close monitoring of the fetus in terms of reversal of flow in the Dopplers, as well as the BPP. So, if there is any indication for urgency to deliver, delivery should be considered, as we are simultaneously treating her fever and hypertension with antihypertensives. That's what I think.
Dr. Leela, you would like to add something?
Definitely, in this 36 weeks, as you were saying, I had a few days back a one case. Patient came with the dengue positive, and she was near term around 38 weeks plus. And that time that dengue, then again we think of that because that patient had dengue, there is chances of vertical transmission of the fetus, this disease to the fetus. So this consideration are looking towards, and we have seen practically that in time that not only the Doppler, you see the oligohydramnios is one of the condition which arises very commonly with the high grade fever. And that patient had oligo and we took for cesarean, irrespective of that, whether she is in a dengue and that baby came out as a dengue positive. So these are the situations. So nowadays the counseling is very important. We have to explain each and everything regarding this fever, that this still we are not a confirmed diagnosis of this. It may be because of the other causes, and these are the indications we may require the delivery immediately. Even sometimes at 36 weeks, it is definitely a late preterm baby, but sometimes to save the mother and for the future of the fetus, we can go for the delivery also.
Yes, Dr. Parag.
Yeah, Niranjan, two things I would like to point out here, especially in women who are near term and with high grade fever. There's a possibility of fetal distress and meconium staining of liquor, and I'm sure all other colleagues of mine who are sitting here would agree to it. And we would also be vigilant about the fetal monitoring, because in fact intrauterine fetal demises are also known with high grade fever. So we have to be vigilant about the baby as well.
Okay. I think Dr. Murlidhar, you have explained very nicely about how to manage this case, about medical disorder, regarding renal disorder, regarding PIH management. You also talked about the fetus, to do a Doppler study, see the fetal, compatibility which is there. And obviously when she goes to labor, accordingly manage with her. Dr. Leela, you also talked about keeping in mind, apart from this, other disease of dengue, and Dr. Parikshit also wonderfully we explained. Now we will move on to the third case, and I don't have any other alternative but to ask you a case who has come with fever, with cough and sneezing. So this lady is about same 34 weeks size in pregnancy, and she has come with pain in the abdomen. I can't resist this question. So I request Dr. Parag, how would you go about to manage this case, investigate this patient?
Okay, even if she's come today, the first thing that, of course, here again there are two problems. One is a possible threatened preterm labor, and second is some infection in the respiratory tract. And even today, I think rationally thinking, our first diagnosis would be an upper respiratory tract infection, right? Any fever, cough, or
Sir, you are being too modest.
No, this is what I personally feel, and I think we should of course be vigilant and have COVID in mind. But the commonest diagnosis would be a respiratory tract infection, and then we have to offer symptomatic treatment. Of course, counseling is extremely important, and if you feel from history that she is likely to have contracted COVID, of course she needs to be referred to a COVID center where she would be managed well.
Sir, what about pain in the abdomen? Will you refer her to the COVID center?
I would certainly refer her to a center where, now see, even in Pune we have medical colleges where the labor and delivery aspect is also will be taken care of. So she needs to be under treatment of obstetrician as well as intensivist for COVID.
Okay. Dr. Vanita Raut, I would like to request you to please give the differential diagnosis and further investigations and management till we come to a final diagnosis.
I think we'll go, even if it's the current scenario, you have to rule out, see, there are two different aspects. What you are saying is fever and the cough and pain in abdomen. Now, pain in abdomen, unless you have seen that there are uterine contraction, the pain in abdomen during pregnancy, many of them will just come as a pain. That does not mean that she is in preterm labor. First, you rule out whether there are any contractions, whether when you do an internal checkup, whether there is any progressive dilatation or effacement. Once that is, it will all depend upon that also. So whether she is in preterm labor or she is not in preterm labor. Consider she is not in preterm labor, then let's concentrate on a upper respiratory symptoms. It can be, as Parag has said, I think one should not directly jump to the conclusion. It can be just a simple upper respiratory infection. Yes, it can be a little more serious than that, like a H1N1 or a COVID. Nowadays, with any fever, any cough, it's advisable to take a swab and send it for a testing for a PCR COVID, because once that comes negative, yes, you need not isolate the patient, and especially a pregnant patient, without reason to get isolated. It's going to have a lot of impact on a mental status also. So once we rule out COVID, yes, we take care of her. If we really feel that it's just an upper respiratory infection, then the symptomatic treatment with decongestant, antitussives, and maybe something like a azithromycin, we can treat it. If one really feels it's H1N1, which of course will have to be confirmed with the antigen testing, then one can also give a Tamiflu, which is very, very safe throughout the pregnancy. If she is in labor, then of course we have to concentrate. If she already completed 34 weeks, depending if it's well advanced labor, and sometimes infection itself can lead to a preterm labor. So it will all depend upon what is the baby weight, what is the baby size. If I can have if I feel mother is not that toxic, yes, and if I can buy some time, I will give 2 doses of steroids and bring about the lung maturity and then maybe deliver her. But if I feel that the mother is very toxic, she herself is very sick, then I'll be little skeptical in giving her the steroids. Anyway, if the labor itself has started, many a times the nature itself will bring about the lung maturity in her case.
So, madam, if the patient is in labor and COVID is just behind our back as a DD, one of them, and she could be H1N1, we have sent her nasopharyngeal swabs. It will take at least 24 hours to 48 hours to come from the lab. So, in that condition, she is also in preterm labor. So, do we wait for steroid to be given or wait for the report, or we give?
Can you just tell again, because the connection was lost?
Madam.
Yes. Sorry, the connection was lost. Can you repeat your question, please?
Yeah. What I'm trying to say that she is in labor, whether she's in preterm labor or she's in actual labor, and she's having fever, and we have collected the nasopharyngeal swab and we have sent it to the medical laboratory. The report will come after
36 to 48 hours, many a time still.
Okay, so what I'm saying is that should we give steroid or we should wait for the reports to come?
See, if she's not very preterm, I would not like to give the steroids. As you said, if she's already in active labor, the steroids are not really going to help. We should take all proper.
Please go ahead. Please go ahead, madam.
Yeah. And if COVID is on high index of suspicion, even our personal protection is equally important, delivering the patient.
Okay, yes, I absolutely agree. Dr. Leela, you wanted to add some comment on that? And after that, Dr. Murlidhar Pai. Dr. Leela, please unmute. And after that, Dr. Murli, then after that, Parikshit Tam.
Yes, can you hear me?
Yes, we can hear you. Thank you, madam.
So if we are suspecting that this COVID and we have sent the test, definitely it is important to deliver in an isolation, patient to be kept in an isolation. And as madam has told us, PP is mandatory. All the consultants and the paramedicals, those who are handling this patient, we have to take all the precaution for that. And this patient, if it is possible, definitely if we are suspecting with all history and other part and clinically, definitely sent to the center where the COVID patients are to be delivered. So that will be again already said that the centers are there where the obstetrician as well as the physicians are available to take care of this COVID. Because once we send this this test for in this COVID, definitely this is to be notified and this is to be followed properly and to be isolated that patient. So once you are delivering in your own hospital, then definitely you have to make a space for the isolation, keep the patient in isolation till you get the report. But there is a question I would like to ask from all the panelists that what about the delivery if patient comes positive? Because one thing we already read till date, even in case of H1N1, if the respiratory distress is there, definitely we are delivering the baby because the mother will improve because once that gravid uterus is empty. So what we will do in case of COVID? Because till date we have no study and no personal experience to anyone that whether we deliver this patient or we continue her pregnancy if she comes positive for the COVID. So tocolytic to be given or not to be given, or the patient is to be delivered. So this is again a question to all our panelists because we have no any experience till date whether to deliver or to prevent the labor.
Okay.
Yes, Dr. Murli.
Yeah. See, your question was whether to give steroids while waiting for the report. I was going through ACOG guidelines this morning, and actually I was preparing for another talk on COVID issues in pregnancy. They have clearly said, because of the clear benefit of steroids to the baby, preterm baby, here the patient is 34 weeks, you put it in a very borderline situation, there is no contraindication as such. In fact, they say they recommend to give steroids. So that much I want to be clear. Now, if the patient is already in severe respiratory distress, ARDS, if she has gone into, or if pneumonia has set in, then it is better we take the advice of the intensive care specialist, whether with regards to giving steroids. Otherwise, if she is in the mildest form of respiratory problems, then steroids can be given. Now, after 34 weeks, like usually they recommend rescue dose of steroids. That particularly may or may not be considered. Whereas before 34 weeks, it is very clear that steroids can be given unless the patient is in severe respiratory distress. Now, second question was with regards to tocolytics. Again, if the patient is in the early preterm labor where you feel that the labor can be stopped, I agree with Dr. Vanita that if she's already in preterm, full-fledged preterm labor, you will not be able to stop at all maybe. But if she's in a very early preterm labor and you're waiting for the reports, you're waiting for the steroids to act, then there is no harm in giving tocolytics either, and the choice is nifedipine. These are the 2 points I would like to add.
Wonderful, Dr. Leela. I hope you are satisfied with the question being answered. I think Dr. Parikshit was also acknowledging the same what Dr. Murlidhar Pai has just told, and it's in 2 parts. One is regarding depending upon the severity of the mother. If the mother is really bad, we will have to withhold the steroid, and more we would focus on the management of the mother irrespective what the period of gestation the baby is. Second is tocolytics to be given. Yes, we can go ahead and go ahead with the tocolytics. Obviously, when the report comes, we will have to be more careful. So she already having these symptoms and signs, I agree with you, Dr. Leela Vyas, that we will have to take all the PPE precautions from the beginning, because same thing we had in our labor ward this week, and she had a case of fever with cough, and so we treated her like a COVID only and managed her, and the report after 24 hours, it came as positive. Then we transferred her to Kasturba Hospital. So I think that's fair enough. My video is on now. I'm sorry it was kept so, but my voice is heard. So I hope everyone has heard my voice. Dr. Vanita Raut, you wanted to ask one question. Please go ahead.
Can any of the panelists tell, suppose if she is known positive COVID patient who came as full term, delivered normally, how do we manage the baby? Known positive, she's not in a distress or something, but she had a mild fever, she had cough, and that's why her COVID testing was done. It was positive. She's come as full term, multi patient, had an uneventful normal delivery. Baby is 2.8 kg, full term baby. How do we manage now the baby?
Yeah, so here there are a couple of issues which are the most important. The first is whether the mother and the child dyad should be isolated and kept separate, or should we room in? That is the first question. And the second very important aspect is about breastfeeding. Then, of course, we have to address testing, etc. So let me take it one by one. The first is about whether we should keep them together or isolate. At the moment, the number of deliveries that we have are not that large. So there is a possibility that the mother and the child can be isolated. In case we go to a stage of community transmission and we see more and more deliveries which are happening to COVID positive women, I don't think it will be possible. There will not be enough bandwidth in the healthcare sector to manage that kind of isolation. And then rooming in and as usual will be needed. If that happens, then the mother has to take all the hand and respiratory hygiene precautions. The second question is, yes, ma'am.
When we are isolated, can she still give the express breast milk to the baby?
Yes, I was just coming to that. So the second aspect is about the feeding. Now, WHO strongly recommends that we should just go ahead and breastfeed. I mean, the mother should give breastfeeding to the baby, use a mask, respiratory hygiene, and hand hygiene precautions. But what I think is that most of the so-called vertical transmissions that have occurred have probably occurred postnatally. So if we don't want the neonate to get infected, the answer is what you mentioned, that it should be an expressed milk. So expressed milk, using all the hand hygiene, a separate breast milk pump that is handed over to somebody who's asymptomatic and not infected, and that person feeds the baby. The third question is when to test the child. Now, as far as the current testing scenario is concerned, we only have the RT-PCR, and the earliest that we can offer that test to the neonate is 48 hours. So nasopharyngeal swab has to be taken of the neonate at 48 hours, ideally at 5 days if the baby is not symptomatic. And fortunately, as of now, every neonate who has had a positive COVID test, there's hardly been a few documented cases. None of them, fortunately, has had any serious impact of being COVID positive. So that's the little silver lining that we have in this whole fairly grim scenario.
Wonderful, Dr. Parikshit. Yes, Madam Vanita.
No, I was just thanking Parikshit for such an excellent explanation, and it's very clear. So there is no ambiguity. This, and this.
Yes.
You taught me well.
Yes, Dr. Murli.
Yeah, I just want to second what Dr. Parikshit said. They have not isolated, fortunately, any virus or viral antigen in the cord blood or in the babies. Only in a series of 43 deliveries that occurred in New York City, they have said only a couple of babies tested positive the first 48 hours, but they turned negative later. Maybe it was just a sort of contamination or whatever it is. So they could not explain that properly. Otherwise, whatever Parikshit said is correct. There is no vertical transmission as such from the mother to the child. It's only through the contacts, and we have to do the same precautions that we have to follow.
Wow, that's so nice explanation by all the eminent panelists. I can tell you there are more than 1,200 users who have logged in, and they are mesmerized by all your opinions, expert comments, starting from Dr. Vanita Rao, Dr. Leela, Dr. Murlidhar, Dr. Parikshit, and Dr. Binniwale. So I think once this patient has undergone labor, she is either delivered normally or by a cesarean section because of an obstetric indication or a fetal indication. We go ahead to the last case.
Yes.
And this lady is fourth day post LACS, a 28-year-old woman. She has fever, and we find on examination that her breasts are engorged. She doesn't have fever with chills or any rigor. And on fourth day, we also find when the dressing is being changed of her LACS wound, there is some pus which is coming. It is greenish yellow in color. And obviously, we did a hemoglobin urine routine microscopy post-op. The hemoglobin was 8.5 grams. So I would like Dr. Parag to please go ahead. How would you diagnose and further manage this case post LACS day 4 with fever?
Okay. Now, as far as the breast engorgement is concerned, good counseling is important, manual expression of breast milk, and then if you are suspecting breast abscess to be there, it can be confirmed by doing an ultrasound of breast, and then action needs to be taken accordingly. Many a times nowadays, if there is a breast abscess, the breast surgeons are recommending aspiration rather than actual incision and drainage. And whatever is drained is sent for culture sensitivity. As far as the wound infection is concerned, this discharge also needs to be sent for culture and sensitivity. And of course, whatever antibiotics has been started to her needs to be continued. The fever needs to be treated with paracetamol. Wound care has to be absolutely proper. And of course, we must look at other possible infections like urinary infections. But you've said that it is not there because the urine examination is normal. We must keep in mind DVT, and we have to keep a watch on that also, because that is one of the reasons why women do get fever, and of course there is a source of infection. So I would certainly like to wait for the culture sensitivity report and then see what is to be done. Of course, breastfeeding needs to be continued, and usually cold fermentation or traditionally cold cabbage leaves are the ones which are used for decongesting the breast, and it works well many a times.
Dr. Vanita, you would like to add something, followed by that, after that, Dr. Leela.
Yeah, if it's only the mastitis which is causing the fever, yes, we can give oral antibiotics. But as you have said, there is a greenish color discharge from the wound. I'll be more skeptical. Whenever this sort of a thing comes, I always remember Smita Patil, someone who in the city of Mumbai has died of puerperal sepsis.
Yes,
so I think puerperal fever has to be taken very seriously. If it is in doubt, one should give very high antibiotics and even a parenteral antibiotics rather than the oral antibiotics. And as Dr. Parag has said, obviously start with a broad spectrum IV antibiotic and switch it over to whenever the report will come. One may even have to send blood culture even before starting the antibiotics. So anything during the puerperal period has to be taken seriously and has to be aggressively. Yeah, thank you.
Yes, Dr. Murli.
Yeah, so what I want to add to what Dr. Parag and Dr. Vinita already said is that two things. One is, you said her hemoglobin is 8 grams.
That needs to be corrected.
Yeah, it has to be corrected by giving blood transfusion to build up her immunity, number one. Number two, somebody said there is breast abscess also. If there is breast abscess, we would rather refer them to surgery department, and it has to be drained. Just an antibiotic will not be enough. The breast abscess is there, it has to be drained, it has to be packed properly, and it has to be dressed properly along with the treatment of the wound infection. That's what I want to just add. And proper immunity in general, to fight the infection.
Yes, sir, I absolutely agree with you. This case had come about 30 years back when I was a house surgeon, and obviously this breast engorgement was there, and you rightly said, we called the surgeons, they did the excision and they drained the abscess, but after that there was a very big cavity, and literally I had to pack a mop every day with that glycerin acryflavin and to push it properly. So this is also which we have to remember in such case. And obviously, Madam has already said that puerperal sepsis has come in mind, and since it is greenish color, it comes in it's basically Klebsiella pseudomonas, which could be there as an organism, and then we have to start on higher antibiotics. Agreed, absolutely. Dr. Leela, would you please comment on
Yes.
that?
One thing is that the high vaginal swab is again required because the puerperal sepsis that then definitely we have to see, because I have seen a case in which a patient had discharged continuously after cesarean, and the 4 or 5 times the cervical dilatation has been done. There was some purulent discharge was there. Patient was not responding. On sonography, the contour of uterus was not properly maintained. Ultimately did laparotomy, and the uterus was just necrosed, and we have removed that uterus in piecemeal. So that is my experience, that it was done by very senior doctor. So I would not say that was the all gangrene uterus was inside that. The fever was not done because the higher antibiotics was continuously given. There was a continuous per vaginal discharge, and all this antibiotics according to that culture sensitivity has given, but this has been damaged the whole uterus. So this, and as Dr. Anita has already mentioned, that even the Smita Patil can have in the city of Mumbai if puerperal sepsis. In our normal gynae patients, especially obstetrical patients in government hospitals, we know what is their hygiene before their delivery. Definitely it will take care of that vaginal part also. So this high vaginal swab is again, I think it is one of the important part we should take care of.
I do agree with Dr. Leela that in spite of good parenteral antibiotics, if patient is not responding, yes, once in a while we may have to go in and do the surgery. I think even in our all experiences, sometimes we have come across that the uterus has become absolutely like it's a pulp. Literally, because it's so badly infected, and in such cases, only the hysterectomy will save our life.
Yeah.
Absolutely, I agree. This was also the rarest of rare case. Last year, we had 2 such cases, unfortunately referred to us from a private hospital on day 9, and there was infection in the abdominal wall, and also the ultrasound showed that there was pus in the uterine cavity with collection at the level of the incision just near the bladder about 3 to 5 centimeter, and also the pouch or Douglas there was pus. So we had to open, and as Dr. Leela has said, it was a totally purulent or a gangrenous type of uterus, and we had to remove that. So these things also have to be kept in our mind. And obviously, I would go ahead and ask this question to Dr. Murlidhar sir. How would you go about to treat a simple case of, not to that extent, but a fever with pus being coming, and what antibiotic? Would you like to change the antibiotic and go ahead?
Yeah, if there is a pus purulent discharge, as others have said already, we have to start broad spectrum antibiotics. Usually, we would like to start one broad spectrum antibiotic. We would like to cover also the gram negatives, and most importantly, anaerobic organism also has to be covered by giving either metronidazole or tinidazole. Then once the culture sensitivity report comes, we have to switch over to that particular type of antibiotic, and we must make sure that the patient doesn't slip into the cold phase of the sepsis. So that is very important. Her hydration has to be kept, her electrolyte imbalance has to be monitored and managed, and general her immunity, her this one has to be improved. So that's what I would like to add.
And then we would like to do the daily dressing, continue, and they might require a secondary suturing after, say, the debridement.
We usually, in a very bad, in fact, day first day we had a very bad case of wound sort of sloughing. So we usually have the luxury of referring them to the burns specialist or plastic surgeon specialist. They put a vacuum dress type of dressing, and over a period of time it will come closer.
Absolutely. So I think wonderful discussion. We have got more than 1250 users online. They are all excited, and I would like to add here there are more than 200 questions which are lined up, but we have got only 20 minutes. I will pick up one by one and I will direct them. This question is from Dr. Preeti. I don't know whether this is from Lucknow or whether it is Dr. Preeti from somewhere else, but it is a very interesting question, and I would like to ask this question to Dr. Parikshit Tang. It is related to IVF, since you are already there doing ART. If a patient is having triplet pregnancy via IVF and we need to go ahead for reduction, and then she comes with high grade fever since 1 week, then how to handle this case?
Yeah, again, let's keep the basic principles in mind that don't do any invasive procedures until the medical problem has been sorted out. Of course, we might go out of the ideal range for doing a fetal reduction, but that's all right. I mean, instead of doing it at 11 to 12 weeks, if I have to do the procedure or recommend the procedure at 13 weeks or so, that's still better than doing it at 11 to 12 weeks with a febrile woman. So I would manage the fever in conjunction with a good physician, get the systemic issues sorted, wait, let her become febrile for at least 72 hours, and then go ahead with the procedure for fetal reduction.
I absolutely agree with that.
Dr. Murlidhar, you are acknowledging the same and you agree?
Yes.
Dr. Soumya Soni, she is asking, I would like to direct this question to Dr. Vanita Rao. It is not displayed on the chat, it is only for me. Madam, this patient has got sudden IUFD in the 3rd trimester of pregnancy, and there is fever of unknown etiology. Now, how would you manage this case, Dr. Soumya Soni? This is not Anita Soni.
If it's IUFD and if she has a fever of unknown origin, I will definitely like to, because see, IUFD does not mean that we should start inducing immediately, because usually the changes which are the related definitely do not occur before at least minimum of a week, usually not even for a month. So if she has a fever of unknown origin, I will definitely like to investigate her, come to the diagnosis, possibly treat her, control her maternal condition, and then maybe induce the labor.
Okay, thank you, madam. I agree with you. We have to do a DIC profile, see that the DIC profile is properly there. Once the DIC profile is normal, the consent has been taken, the fever has been under control, and obviously we can wait for some time till that report comes and we can induce her, but a fever has to be, we have to find out what is the source of infection, give her antibiotics empirically, and I'm sure the fever will come down. And as nature also in some of these cases, as you said rightly, madam, before, that when the fever comes in, this patient also starts in the process of abortion or in the process of delivery. So God is very kind in such cases. So I'm sure we have answered Dr. Soni. Now, Dr. Pai, we have the next question from Dr. Lalitya. What about the care of baby after delivery of a COVID positive patient? Kindly add a note. Next part, kindly add a note on who must be taking care of the baby.
Yeah, actually, Dr. Parikshit has beautifully explained the 3 different issues that are concerned with the postnatal care of the baby. One is rooming in, he has already answered. As far as possible, it has to be kept separately, and somebody else who is should be managing that. And as far as the breastfeeding is concerned, he said, WHO guideline, if you want to breastfeed yourself, then all precautions have to be taken, but the better would be to give express breast milk. And of course, there is no different management of the mother and baby other than the general rules to handle a case of COVID.
We find so many videos which are there. There are babies and there are 2 nurses who are feeding, breastfeeding, the mother is isolated, the baby is isolated. So I think you have given a apt answer and given justice to this question. Thank you, Dr. Pai. We move on to Dr. Leela Vyas. Madam, the question is how to proceed of PUO in the 2nd and 3rd trimester in pregnancy. This is Dr. Surya Kumari. Raja Mundri. Actually, we have answered this question, but probably the caller has joined little later after the question was taken. So, how would you manage a PUO case in second and third trimester?
That's in second trimester, if high grade fever, the first thing is that the temperature should be bring down, because the high grade temperature, it causes the preterm labor. And in the late third trimester, again, there is chances of even the IUD can occur. All we have seen that the meconium strain discharge, and this after dengue, we have seen the oligohydramnios there. So the temperature to be bring down, first thing is that if the preterm labor is going, because the preterm labor is because of this high grade temperature. So this first to be bring down, and definitely we can add on the tocolytics to prevent that preterm labor and find out the cause of that fever and treat accordingly. Definitely it is to be required. And again, according to the maternal situation, the termination of the pregnancy will be done according to that maternal condition, how the maternal conditions are there, whether this cause of fever is deteriorating the more to the mother. As we all know, the malaria, if the simple malaria is there, which is more serious in the late trimester. So this, we have to see what is the cause of the fever, and according to that, the obstetrical management to be planned.
Okay. Dr. Parag, I would like to ask you the next question by Dr. Oh, this is Dr. Satish Sanjanwala. He was our professor honorary in RN Cooper Hospital, which is right now the HBT Medical College. We know Dr. Sanjanwala. Thank you for joining with us. Obviously, he has already written the question. We say hi to him. Dr. Parag, you can see on your screen, this patient was fever with pregnancy. How early the diagnosis of COVID-19 can be arrived at, and by what test in view of the present situation? That is the first part. So, can you answer that? How early can you diagnose COVID-19?
Currently, there are
asymptomatic. So, asymptomatic patient, do they have to undergo any test for COVID-19 in pregnancy?
at this point of time, it is difficult because the guidelines do not allow us to screen asymptomatic patients. So, Government of India has very clear-cut guidelines for testing for COVID-19, and we have to be adhering to it. Yes, Niranjan, you want to say something?
Here she has now fever with pregnancy.
Okay, fine. So again, as I mentioned earlier, detailed history has to be taken, and if she comes in that category, of course, she can be offered this particular test. But currently, what Pune Municipal Corporation has guided us is that such patients need to be referred to the COVID centers, where they will be admitted, they will be investigated as per the protocol, and they will be managed. This is what is the guidance that we all have received in Pune. So currently, the test that is being done is the throat swab, which is collected, and then the sample is tested by the PCR test.
Any hematological test? This is the second part Dr. Sanjanwala is asking.
Yeah,
Rapid test.
Any blood
rapid test as of
Rapid
now,
test is
rapid test as of now have not been approved. So that is something which is out of question now.
It's
The only
approved
one
by ICMR, but we don't have the kits.
Yeah, but then as of
It has come now.
none of the guidelines are recommending it. So I think let's not talk about it. One thing that can raise suspicion is the low WBC count on the peripheral blood smears, because that is something which can give us a clue that if the patient has fever and low WBC count, probably these pandemic times we are dealing with a patient who has COVID.
Okay, Dr. Pai, you wanted to add something?
Yeah, the question is not whether ICMR has approved or not, whether we have the test kit or not. The question is, if you want to do the rapid test or the immunological test, it is late. You know, the immunoglobulins have to be prepared in, have to develop. So the early test is still PCR.
Okay, thank you. I think Dr. Sanjanwala, we have answered your question. We move on to the next question now. It's a very, very lengthy question. I will try to apprehend it. Dr. Hiremat P. Dr. Hiremat P. He's written this question. I am directing to Dr. Vanita, madam. She's third gravida, G3P2 with no living issue. At 24 weeks, she has come with high degree fever for 2 days. Ultrasound shows that the fetus is live with severe oligohydramnios and not able to visualize the fetal kidneys, not confirmed renal agenesis. Blood investigations were done, they are normal. Dengue and MP are negative. Now, at 24 weeks, is it justified to terminate the pregnancy, keeping in mind the possibility of chorioamnionitis because she has got fever for 2 days, as the prognosis for severe oligohydramnios at 24 weeks itself is questionable? Madam,
I think
very lengthy question.
no. If I did not get that part of it, even if there is a severe oligohydramnias, you can make out whether the kidneys are present or not. So I'm sure that the kidneys are present, and now there is a severe oligohydramnia. So, which points that probably this patient has leaked some time back, and because of that, she's got a severe chorioamnionitis and leading to fever. In that case, I don't think with such a, because you have ruled out many other causes of fever. So the only thing probably which is pointing, of course, you'll have to see clinically whether there is uterine tenderness, whether there is any foul smelling discharge, what is the report of your high vaginal swab, leukocytosis is there. I will be more inclined to terminate the pregnancy because at 24 weeks, such a severe oligohydramnios who's already symptomatic, this patient, if you prolong, it's not likely to reach salvageable age. So I would be in a more tempted to terminate, but definitely once control the fever with antibiotics, control the infection, and then go ahead with the termination. If not complete control, at least give 24 hours of IV antibiotics and then proceed with the uterine uterotonics or whatever the way you want to terminate the pregnancy.
Okay, wonderfully answered. I would like to go, there are many questions, 10-15 questions, but due to lack of time, I will be taking only the last 2-3 questions. Dr. Preeti Sharma, she is asking this question. Dr. Murli, what is the degree of fever which can damage the fetus in a pregnant mother? Next part is, what is the maximum dose of paracetamol which can be safely administered to a mother in a day? In one day, how much paracetamol can you give to a patient who is having fever with pregnancy?
Yeah, usually we give 3 times a day, the paracetamol. And as far as the degree of temperature, it depends, depends upon the patient's tolerability. But anything more than 101 or 102, we should not be waiting for it to go further higher. The lower you bring down the temperature is better for the patient. And as I told earlier, if the mother's temperature is X, then the inside the uterus temperature is X plus 1. That is what should be guiding us. And that is more dangerous not only to the mother as well as to the fetus inside. So I have not seen any particular upper limit, so I don't want to guess and answer that. So it is not advisable or it is not prudent to allow the patient to go for high degree fever and then only start treating it. So anything in puerperal situation, it is very clear. Anything more than 100.4 is considered as morbid puerperium or puerperal pyrexia. But in antenatal period, there is no such definition that I have come across. If anybody else has come across, they can tell us. But generally thinking, better not to wait for a very high degree fever and then only start paracetamol.
The maximum dose of paracetamol is 4 grams per day.
Okay. I think we have answered that. And now I move on to Dr. Leela Vyas. Madam, very interesting question. This is Dr. Kamlesh Mishra. He is our regular doctor who logs in. I would like to thank him today also on weekend. He has logged in. His question is, in fever, will you give chloroquine at 8 weeks if she is COVID positive?
Regarding this chloroquine is safe during pregnancy. But in case of, means you want to give this chloroquine as a treatment for COVID or as a treatment for malaria. But they wanted that in COVID patient, the chloroquine. Definitely the chloroquine is safe during the pregnancy, we can give it. But the treatment depends on the COVID experts, not by the obstetrician only if she is COVID positive.
Very important point you have raised. This question is Dr. Shama Kadav Kolan. Dr. Parag,
Yeah.
near-term pregnancy, she is near-term, she has got high fever, she is vomiting, she has got cough with expectoration, and there is no history of exposure, normal blood, urine reports. Does she require corona testing?
She definitely needs assessment by a physician, and then if the physician feels we should go ahead and do an X-ray of chest at least, and then depending on the reports, we should take a call as to what is to be done further. Right? It is still possible that we are dealing with a case of lower respiratory tract infection, but if she continues to have symptoms in spite of treatment, it is worth considering the COVID testing.
Very good. Thank you, Dr. Parag. I know you have an emergency which is looming. Can we know what is that case?
No, I have to rush for a C-section. There's a distress in the hospital, so I'm getting distressed now.
Yeah, so thank you so much for joining. We will
Thank you so much, Niranjan. It was my pleasure, and nice to meet Vanita, Murli, Leela, and of course
Nice
you
to
and
see.
Yes,
Nice to see.
Thank you very much.
Okay. Even Niranjan, if you don't mind, even I need to rush. Can I please leave with your kind permission, moderator?
Madam, just last question. Last question.
Okay.
Yeah. This is very interesting, and I want each one of your opinions. There are many questions, but we will have to finish. We will take this last question now. We come to laparoscopic surgery. In COVID times, laparoscopic surgery has to be done, not to be done, which anesthesia and sterilization. This is Lady Dr. Nandini Illumalai. Now, please guide her whether we should go ahead with MTP with lap sterilization in this COVID times involving general anesthesia, and if not, till how long to withhold that lap surgery?
The guidelines are avoid surgeries as far as possible if you have the medical line possible. Like suppose, not in a gynec, but suppose there is appendicitis, try and give antibiotics, try and avoid the surgery. Second guideline is, as far as possible, avoid laparoscopic surgery and do the open surgery. So even a ectopic, you can just take a small incision and do the ectopic. Third, I think pertaining to her MTP with lap TL, I will definitely not like to do lap TL in such a patient and in such a scenario, because with sterilization operation, one small thing which goes wrong, whether it's because of your sterilization operation or otherwise, the repercussions are quite a bit. So I would definitely not like to do a laparoscopic sterilization. Maybe she can go ahead with the termination of pregnancy, which is much more smaller in a degree as compared to the laparoscopic sterilization, which can be even done under local anesthesia with a sedation, and one does not have to expose the anesthetist, everyone, to the general anesthesia, and then when they extubate, the aerosols being liberated, and then she can use some other form of contraception, and the permanent sterilization can be done at a much later stage.
Thank you. Dr. Murli, would you like to say something?
Nothing to add, not even a single comma.
Dr. Leela?
No planned surgery, nothing.
Absolutely beautifully.
Dr. Vanita Rao is the final authority, and we have got one more last question. I can't resist this. It's a very broad. Again, we come to paracetamol. How many days can we manage patients with only paracetamol? Dr. Vanita, you have already answered, but for the benefit of our viewers, I would like to say already you have said 4 grams we can give in a day. This is very important by Dr. Meena Agarwal. She wants to know how to go about to treat a typhoid in pregnancy. Dr. Murlidhar Pai.
Typhoid treatment, yeah, you can actually give now second or third generation cephalosporin, and it can be treated. Not an issue.
Okay. Fine. So it was a wonderful to have you all on this weekend. I would like to say we had 1250 users. They were not only from India, pan-India, but they were from Southeast Asia, Europe, and even US was awake. And thank you so much for being here with us. Today, all the fever has gone down now. There is no more fever in anybody's mind. Most of them fever issues are resolved, and I hope this COVID things lockdown goes as early as possible. I would like to thank all the esteemed panelists who have come here, and thank you all of you, Dr. Vanita Raut Madam, Dr. Leela, Dr. Murlidhar
Thank you.
Bhai, Dr. Parikshit, Dr. Parag Binnewale, Dr. Komal Chavan, and last but not the least, Dr. Jaideep Tang, our president, who we acknowledge. This was our first MOGS live webinar. More than 1250 members joined. And I thank you, all of you. Have a wonderful weekend. Be safe, play safe, be happy. And we will work more towards aiming that COVID goes as early as possible from our country. Thank you so much. Flatten the curve. Stay safe. Social distancing. Thank you, Science Integra, for this wonderful TOG webinar. Thank you, all of you.